Good afternoon, everybody. Thank you for being here with us. Happy Tuesday. If you're a taco aficionado, happy Taco Tuesday. We're excited that you can be here for part 2 with Dr. James Henry of Trauma, Mental Health, and the Brain. This is actually part 2 of a 4-part series that we are collaborating with him on. If you need McBath credit, please drop your name in the chat, letting me know that you need that. That is our way of verifying that you have attended this webinar. This webinar will also be recorded. You are welcome to turn your camera off if need be, but just know in the final editing process, actually nobody's face is on there except Dr. Henry's and myself when I'm speaking. So I'd like to introduce you to our guest of honor today. Dr. Henry joined the School of Social Work faculty in 1997, and after 17 years in Child Protective Services, Dr. Henry teaches courses in child sexual abuse, child welfare, advanced treatment of children, and human behavior. He serves as the co-chair of the Kalamazoo Community Mental Health Board. Welcome, Dr. Henry.
Thank you. Welcome, everybody. I know some of you were here before, and just to kind of frame me, I have been on the chair of the Mental Health Board, but not for a while, so that's an older one. But certainly I've been sitting with children and families for the last 23 years as the director of the Children's Trauma Center, and now I'm the project director of a SAMHSA grant that we do family assessments. And actually, I'm up here in the Upper Peninsula with my colleague doing assessments of children and working also with parents. So I'm excited anytime I can talk about children and understanding them, talking about parents and understanding them, and families and adults in terms of what trauma does to the brain, what trauma does to functioning, and how mental health and trauma intersect. And I know we talked some about that the last time. And so I want to kind of build on what was said, although I'll kind of have a 2-second review of the brain just so we're all on the same page. And I want to start with and talk about some examples that have happened in the last couple of days. To me, it's always one of those important, emotional, and grounding experiences to talk about the here and now. So it's actually yesterday and today that I'll speak to some of the case examples to kind of then translate into understanding the brain, trauma, and mental health. So thanks for being here. I certainly want questions, and I will stop periodically for looking at the chat box that Kristen will let me be aware of. But please, at any point, raise your hand any way and anyhow that you want some further information, or just say, hey, help me to better understand this, or I disagree, whatever it might be. But it's always best to engage. And one of the things I said to the little girl I sat with today, who's 11 and a half, is I'm here to listen to you because you're the expert of your brain, and I would like you to teach me what it's like to be you. And then I can help other people understand that. And I think when we start with that framing of empowerment, to be able to, from a child's perspective or an adult's, I'm sitting with a child today, but the adult piece of that is the same. You're the expert. That's the empowerment. And when people feel empowered, then there's much more opportunity to be able to join with them and to provide a safe place for them to feel understood. So that's the context. So I'm going to start with some PowerPoint and we'll go right back to right here. So Dan Siegel, brain expert, physician. He's written many books, The Developing Mind, just amazing in terms of understanding the impact of trauma to the brain and the impact to experience to the brain. But one of the things he says is neurons that fire together wire together. So in other words, our experience in the moment create pathways, and those neurons then make connections. so that when we have a memory, often if that memory is intense, doesn't have to be traumatic, but there's an emotion tied to that. So they're wired and firing together, and then that brings the experience back to a year ago, 5 years ago, 10 years ago, whatever that might be, because they're connected, all right, in that neural pathway in our brain. So really want, when we talk about some of these examples, what's wired in those children and adults that then impact them in the moment, even though it happened significantly in the past, all right? The other is this one, and I used this last time, and I really just wanted to show you this again. And for those who are here for the first time, this is Bruce Perry's upside down triangle of the brain. And so it really is a great representation. And if you look at the bottom is the brainstem, and our brain develops from the bottom up. And so if you look at the brainstem is heart rate, respiratory, then you move to diencephalon, which is much more arousal. If you think of a 3-year-old, 2-year-old moving, gaining motor, gaining awareness. Then there's the limbic, the emotional system, which certainly is based on attachment and how that emotional system develops. And then there's the neocortex, which is our thinking center, where we have abstract reasoning and executive functioning. So this is important because trauma most significantly affects the bottom 3 areas. And so it becomes, as many of you, if not all of you, are familiar with the work of Bessel van der Kolk, the body keeps the score. All information goes through the body, up through the brainstem, and then to the higher levels. And often trauma is stuck in those lower levels, which then affect our ability to function. And so as I share some of these, I'm going to ask you to think about what might be happening for this person's brain given some of the experiences that I will share. So as we look at this, and we also know that it's much easier to change our thinking in the neocortex. I can learn new information, much harder to generate change in the limbic. In other words, I might want not to do that again in reactive emotionally, but I'm triggered because it's much more difficult. And the lower in the brain, the more difficult it is. And that's why trauma is so significant, because in some ways it overdevelops that lower part from the limbic to the brainstem. Some people call that the primitive brain. Some people call that reptilian brain. But the most important part of that is recognizing and understanding that I can know something, but if the rest of my brain, neurons that fire together, wire together, is in that state of fear, of danger, of harm, then that's going to overtake often my thinking and direct my behavior. And so that becomes so significant, especially when you have intrusive thoughts. In other words, going back to an event that happened where you felt in danger, where you felt powerless, where you felt this threat of harm. And so that then, in some ways, significantly alters my ability to think through a situation because the lower part is taking control. And when kids have had a lifetime, however long that might be, in their development in a family that where there is chronic trauma or what we call complex trauma, then that wiring moves them through and significantly has the potential to affect their functioning. So as we are thinking about this and looking at understanding beyond the behavior, one of the challenges for me with mental health is we sometimes can get stuck on the behavior. I mean, the DSM-5 and certainly those prior were all built on symptomology. In other words, what are the symptoms? And then this is the diagnosis versus the etiology, which is what's the cause. And so if we can think about causation and look at the brain as critical in determining what and how that person is functioning based upon their experience and how they make meaning of the world. And so that is the second part of this, is that all of us create narratives, and those narratives are how we make meaning of our experience. And so in the way we make meaning then significantly impacts how it affects us in terms of behaviors, in terms of responses emotionally. And so we want to make sure that we understand that the brain is making meaning of whatever happens to us. And in that way that it makes meaning, it has then the potential to affect us in small ways or very significant ways. So these three scenarios, just think about what and how these three, I'm going to go one at a time, how their brain might be wired. So scenario one is Hank, and Hank is 15 years old, and he's currently in foster care, and he was removed 3 times from his birth parents for physical abuse, neglect, and parental substance abuse. And it dates back to 2007. And so he's been in foster care, and he has had 15 placements. Okay. So he's got 15 placements, which then when we say, how is his brain wired? Thinking what? That there's rejection, abandonment, people don't stay. One of the questions I asked him is, are these significant events in his life? And he said, the first one is people lying to me. They've told me they've cared about me, but they've never followed that through. And so if your perception and the way you've made meaning is that people don't stay with me, don't want me, then the internalization is there's something wrong with me. And so for him, he has this array of mental health diagnosis, ADHD, which is very common because of his hypervigilance. So the brain's constantly scanning, and so his concentration, attention is affected. ODD, meaning oppositional defiant disorder, and that surfaces out of, I can't trust adults. One of the most significant statements he said to me was, after all that lying and what people have said, and it hasn't come true, I can't trust anybody. And so if you can't trust anybody when you are told something, and if your experience is that adults are safe, then you're much more apt to positively respond versus, I can't trust that you really have my best interest at stake. And so I become defiant because I can't trust. And the other part of that is believing that you have the potential to hurt me. And then we have conduct disorder, which again is breaking the law. And so he's run away at least 30 times in the last 2 months. And that kind of behavior, when we're looking at strictly from mental health, is that meets the criteria for conduct disorder. Whereas if we're really understanding 15 placements, continued physical abuse in his biological home, and neglect, then what's happening is really cord in his experience. And then the last one is PTSD. Now, I want to say this because I think it's important, because PTSD is a mental health diagnosis. And when we say PTSD, we mean intrusive thoughts, we mean hypervigilance, hyperarousal, why that often correlates with ADHD, and in that sense of avoidance. I don't want to talk about it. I don't want to think about it. I'll pretend it doesn't happen, even though it's still in my brain and even though it's still affecting my body. So when we think about him, how might his brain be wired? It's wired for the expectation of harm, which then puts the brain on high alert. And if we're talking about that diagram, it rests in the brainstem, because whenever we're in survival, our brain moves to lower in that system in order for protection. And so he's constantly moving into, for him, flight, all right, which is 30 times running away in 2 months. But it's also fight, as he's gotten in several fights. And he talked about that He said, my first response is to either run or fight. His ability, his neocortex to think through consequences, he kind of had this chuckle when I said, well, tell me about when you're getting ready to fight or flight. What are you thinking about may happen? And he said, I'm not thinking about any of that. All I'm thinking about is how I'm going to survive. And so as we look at this and understand the context of his behavior, his diagnoses, and its connection to trauma and that continuous danger, putting his brain in survival. So if we look at this and we think about executive functioning, which is in the neocortex, and that's where we bring what we know, memory recall. We can focus on what's happening around us. We can then plan, organize. Self-monitoring of behavior and action means I'm aware of what's happening inside of me, and I have impulse control, and then my ability to regulate emotion. Now, that's a lot. And if your brain is in that bottom of the triangle, then these are significantly compromised. And so when we see reactions of significance, one of my first questions is what's happening in his executive functioning, and how can we explain what he's doing not as good or bad, but rather a effect of how and what he's had to do to survive. So trauma compromises, as I said, his executive functioning and leads to those very significant behaviors of fighting and flight. Now, the other one is this scenario. So here's a young girl, and I saw her this morning. She's only 11. And when she was 8, her mother told her that she was a product of a rape, right? And so just think about how she makes meaning of that, meaning this girl, in being told that. The other part of this is that she's had significant exposure to abandonment and rejection and substance abuse. And so when I asked her what was one of the most significant events that has impacted her, she said, my dad, when I was 10, would leave me home for long periods, meaning days at a time. And often there was not food in the house. And so I was worried. Is something going to happen? I was worried about food. And she said to me, I worry all the time now. So anxiety. So it'd be likely that we might see, from a mental health perspective, a diagnosis of anxiety, when in reality, it's not a genetic composition for her as much as that experience. The other thing she said is now, and she's in foster care, now that I can eat, I eat quickly because I'm always worried it's going to be taken away. Neurons that fire together, wire together. Food scarcity creates binging. Food scarcity, insecurity creates this need to hoard food. And so as we talk about, for one, thinking there's something wrong with her, and two, this worry, this sense of harm pending, always wondering what's going to happen next, and am I going to be abandoned and rejection. The other part of this is in terms of thinking about, as we look at her diagnosis is only ADHD. Now, I sat with her for over 2 hours and she did not smile once, okay? And she was very straightforward, and she did communicate some of the things that she struggles with. And the number one internal struggle is, do I belong anywhere? And does anyone really want me? So if those are the internal messages, then certainly there's this high risk for depression. there's this high risk for disassociation in terms of pulling back. And there's this high risk, as I've talked about already, of this ongoing anxiety because I don't know what to expect next. So when we think about her brain, it's a picture of a woman who painted her way back to healing. And it really, to me, speaks about making meaning in my brain in terms of how come this happened. And as you see here, this woman was raped and physically abused. And so all of these questions, if I only had, I did it, it's my fault, that continue to be intrusive and then disrupt any ability to feel safe. And so I think this picture, even though this was done by an adult, really speaks to this young girl at 11, those very things that she's continuously thinking about. She said to me, in school, it's really hard for me to concentrate because I keep going back to the things that have happened. The other is, it just feels like everything is always my fault. And so if I was different, maybe this wouldn't happen. This right here is a picture of 5 corpus callosums, and those are the wirings from the left side of our brain, which is the analytical, to the right side of the brain, which was much more the creative, emotional. And so you have this analytical, logic, language. That's how we talk to ourselves. And then we have this more emotional, creative side. And so it's so critical because the corpus callosum connects the two. Now, what we've learned in research, obviously, and this is a picture of corpus callosums that have been affected by fetal alcohol prior to birth, all right? And so this one on the left, as you look at this, there's a pretty close to a normal sized corpus callosum. You see that kind of oval shaped where the line is pointing. The second one, it's more distorted. And the third one, there's hardly any corpus callosum. And the last 2 don't have corpus callosums. And so Martin Teicher, who's the expert on trauma in the brain and corpus callosum out of Boston, speaks that these slides represent trauma, chronic exposure, that then physiologically the brain and the corpus callosum begin to narrow and they begin to get smaller. And just imagine for a moment if you or I couldn't talk to ourselves as we get frustrated, because part of most people's coping is, okay, calm down, count to 10, take a deep breath, different ways. But if you're physiologically, that's not available, how would that affect your behavior? And so we might see behaviors that might look like bipolar. We might see behaviors that look like mood dysregulation. And so we could say, all right, those are the symptoms, but really understanding the etiology helps us as we approach that it's not what's wrong, it's what's happened. One more scenario, and this is a young girl who's 10, and her birth mother died when she was approximately 5 from a drug overdose. And so he was placed in foster care, and then her father was placed in jail, and now is back in foster care. And so she's diagnosed with ADHD. And if you look at these and you think, gee, how does this meet ADHD from a mental health perspective versus recognizing the global impact of multiple experiences for her that then affect how she thinks about herself, how she thinks about the world, and how that affects her functioning. Okay, so I'm going to stop right there for a second. But before I do that, I wanted to show this because, again, we have to recognize that chronic exposure to danger, harm affects physiology. And so here's a Bruce Perry slide of A child on the right who is extreme neglect in an orphanage versus a normal size from a top-down view. And again, being able to appreciate that behavior is not just, quote, a matter of choice, willfulness, but an impact of the physiology. And secondly, how I perceive the world. And so in that twofold process, we can then recognize and respond and increase our empathy, because as soon as, whether it's an adult or a child, we view it as willful, empathy decreases, our judgment increases, and our willingness to engage also is affected and compromised. So let's stop there for a second. I'm going to talk about, I want to know if there's any comments in the chat box or any thoughts that people have given those three scenarios.
There's nothing in the chat box, but if you do have a question or a comment at this time, you're welcome to unmute yourself and say your question or comment.
All right, so let's go to this. So one of the things, it's so important that when we're understanding trauma, mental health in the brain, is how appearances can be deceiving. And so this was done by the woman who did the picture of It's All My Fault. And if you look at this, one of the things that we know of coping in the lower parts of the brain is we can learn to placate. We can learn to meet other people's needs, so maybe they will like us. So maybe they won't hurt us. And so for this particular picture, it demonstrates, especially in adulthood, I can have a smile, but the shame of what's happened is with me all the time, that I'm not as good as others. Or this happened to me, as I said, of the 11-year-old girl, because there's something wrong with me. And so shame is very important because it really severs our ability to believe that we have value, because seeing that we're not as good. So placating, this need to please others, internalizing, I'll hold it inside. One of the things the 11-year-old said to me today was, I don't tell anybody any of this, and I just pretend it doesn't exist to other people. And yet it's still impacting. She internalizes that depression. And yet another way to see this is, okay, looking fine, but then comes the explosion. And so the brain flips, going back to executive functioning, the brain flips and now is being driven by the brainstem and is not being driven by my thinking. And so for that first boy who's 15, this overwhelm and stress overwhelms the system to cope. And the more trauma one has had, the greater reactivity there is to small amounts of stress. So what somebody's window of tolerance, we call it, who has had safety and comfort and trust, can manage more stress without getting out of their window, either a shutdown or, in this case, a reaction, becomes essential to say, how come one person can handle this much stress and someone else this? It's dependent on that wiring in the brain and what it triggers in this moment of what's happening around me. So this internalization and this externalization. And so it can vacillate up and down very significantly, or it can be always in this kind of fight flight stage, or just that disengaged dissociative state. So as we look at this, if we think about sexual abuse, I want to use this as an example of trauma, obviously, this violation. And if we think about an event of sexual abuse happening, there's a traumatic impact. Now, how much of that impact is dependent upon what we do after the event and with the impact that already's been experienced. The longer we wait, the less we don't address, the more this happens. So the greater the experience of impact. And soon other people are responding to this person and their traumatic impact in negative ways, like you don't care, you're not trying, you could do it if you wanted to. And so what occurs is the impact gets larger, and that's driving functioning. And in driving functioning, then it continues to reinforce the wiring in the brain. So that ultimately, even though the event has happened significantly in the past, the impact has grown and then rippled throughout that person's life into adulthood. One of the things I was telling Kristen, I just came back from Los Angeles and was presenting at the International Society for Traumatic Stress, and I was in a group of presenters on mass violence, and I've been working in Oxford for a couple of years after the shooting. And there was a study that was done in Norway. There was a horrific shooting and killing of many, many people in Norway, and part of those were teens. And they've now done a 10-year study. They just finished it, and 42 to 45%, now they're adults, of the adolescents. When it occurred, they were adolescents, but now 42 to 45% have depression, and over 40% have significant sleep problems. Now, what that tells us is how this picture is an accurate reflection of how that impact can get even larger and then create more anxiety, more fear, and more functional dysfunction. So really important as we think about how this looks. The other part, and I wanted to show this, is this symptoms of child abuse is the multiple areas. So trauma is not the event, trauma is what comes after the event. That's when the wiring in the brain happens. That's when my perception shifts. That's when my behavior can be so affected. And so if you look at this picture, there are 3, 6, 7 different areas that have been very affected in terms of my lips are sealed, I can't speak, blockage, I can't feel, loss of memory, I've closed off, and that's that avoidance of PTSD, this chronic helplessness, and the dead zone, where the sexual development drives, because as you see, the enlarged area development, and yet it's dead. It doesn't provide the intimacy that sexuality was meant to provide. The mother of the one girl who was 11, who I was telling you about, we did an assessment on her, and she had been severely sexually abused from the ages of 7 until 12. And she said, I became very hypersexualized. And in that hypersexualization, I equated love with sex. And so I was constantly seeking that out, but it didn't bring any sense of satisfaction or emotional connection. Matter of fact, it was dissatisfaction and dysfunction in relationship. So the other part about this that I really want to explain that's really important is for the adults, and often you've heard the term and the diagnosis of borderline. And what borderline, 90% of borderline personalities have experienced sexual abuse in their development in childhood. And what we know, it's this kind of vacillation between helpless, clingy, I need you, to then feeling pent up anger so that a relationship is all good or all bad. And so we're all social beings, we want relationship, but the closer we get to it, if we've had that history of sexual abuse, the greater we push back because we're afraid of being rejected and abandoned and harmed again. And so this approach avoidance, it's called, swinging from helplessness to pent-up anger. And so as we look at and understand trauma and its impact, then what I see with kids, and certainly with adults, is then they begin to reenact that sexual abuse, especially if you're a male, on other children and through adulthood. And so it fixates, we talk about fixated aggressor is where that abuse has occurred and they haven't moved beyond that and they keep reenacting. And so I was sitting with a boy literally last week who had sexually, he's 15 and had sexually touched his 7-year-old sister. And when I was sitting with him and talking, I said, sometimes our bodies take over and our brains say no, but our bodies seem to have more power. And then we find ourselves doing something that we know we shouldn't. And he shook his head and he said, that's exactly, I know I shouldn't. And I'm trying to learn not to. But what happened was I didn't think of the consequences. Again, his brain flipped, stimulated by the sexual experience and urge of his own abuse that then resulted in the abuse of his sister. So as we look at this and understand the complexity, and if there's any kind of takeaways, it's when we simplify complexity, it's so that we can manage it as people who are working with others or in the same family, versus embracing the complexity of the brain, the wiring, my own experiences, and how come this is happening, and looking at it from a much different viewpoint than a simplistic one that culturally we created and certainly adhere to, of choosing good over bad. And if you choose good over bad, then you'll do well. And if you choose bad over good, then there are consequences and you'll learn from those consequences. Unfortunately, when your brain has been traumatized and your executive functioning, which is, again, that ability to problem solve and to think through before I act, when that's not available, consequences don't work. This boy who has run away 30 times, he spent 2 years in a residential facility. And he said, I learned to survive in that residential, but I'm even more reactive because of how that physically and emotionally harmed me to be there. And yet he received all kinds of consequences. Consequences don't work often when the experience of trauma takes over that lower part of the brain and, again, restricts it from entertaining and getting to that executive functioning. So I want to just talk about this for a minute, this kind of understanding trauma. And this is from a sexual or from any type. So this is obviously a Calvin and Hobbes cartoon. And whenever I take a bath, I always put my ducky in first. For companionship, no, to test for sharks, right? So what's benign to me, a bathtub, is seen as dangerous to another because of the wiring in the brain. And I think this cartoon speaks so powerfully to then the experience of neurons firing together, meaning water, danger, and now I have to figure out how to test, is it going to be safe? One of the things the 15-year-old said to me yesterday was, because I can't trust, I always have to test. And the more I test, the more I can see, are they really trustworthy? And yet what I see over and over is that there's never one more thing. And if just that happens, then my wiring will go away. The wiring is always there. What we're trying to do with healing trauma, building resiliency, is building new pathways, new neurons that fire together, wire together, of social support, of empowerment, of a sense of self that then puts me outside of believing there's something wrong with me to somebody did something to me. And so we're building and managing from that rewiring. So the other part of this, and I talked a little bit about altering perceptions of self, but this is where shame comes in, that I'm different than everyone else and I can't be the same. One of the things, I ran a group of sexually abused girls for several sessions many years ago. And one of the things that they would say, these were high school girls, and they would say is, when I walk down the hall, I think that everybody knows what happened to me. And I know in my prefrontal cortex, they don't, but it feels like they do. And then I just feel so ashamed because thinking it's because of me that it happened. And I think, again, changing the wiring in the brain is the most difficult thing to do. And as I said in the first talk, it can't be done through talk, it has to be done through experience. One of the mistakes social workers often make is to meet folks and say, hey, I'm Jim, I'm a social worker, I'm here to help you, and you can trust me, right? Well, no, you can't trust me, and I don't expect you to trust me. I want to honor the distrust rather than believing, because I believe I'm trustworthy, that you should, which totally dismisses the other person's perception of the world. So one of the things I just want to, and I did talk about this, but I just want to kind of shape this in a little bit stronger way. And that is this idea in sexual trauma. It's one, about relationship of violation, and two, because it stimulates the sexual organs, then it creates a hypersexualization. And so we see this in young children who begin to be hypersexualized. And so this body taking over, again, the lower part of the brain taking over in ways then that create harm to themselves and to others, becomes really significant, because it isn't about moral judgment. It's about what's happened and how the brain then is wired. So this reenactment becomes really important. The other part of this is to recognize that young children have the plumbing and it can feel good, and often does. And so when something feels good, we tend to repeat it. And so this is part of that reenactment, is then it helps me to feel good. And I don't have the executive functioning control because of being a young child, that then the older I get, the more I have. That's why sexual development is such, usually, that happens in adolescence and beyond, because there's more ability to control the impulses that children don't have, right? So I just want to show you this picture just to show how this can wire a brain and come out in a very benign circumstance, but a very profound way. So this boy was asked to draw a picture of a person. And so as you see, he drew two people, and with genitalia, looks like each of them had a penis, and you see where their eyes are going. And so in this picture, what he's telling us is that his world has become sexualized as he draws, from asking just to draw a picture to this scene of sexuality, and not only sexuality, but with and seeing someone else. So when I saw that picture, I said to his mom, he didn't come in for this sexual abuse. But when I saw his mom, I said, tell me, has something happened to him? Are you aware of anything? And so interestingly enough, she said, well, in our apartment complex, my son said that somebody had touched him, some adult had touched him, and we called the police. They investigated, but didn't find anything that was substantial. And so clearly, this picture in and of itself tells us what's going on in his brain and how he perceives the world. And that's hypersexualized identity. The other part of this, and I've mentioned trust and betrayal, but in the experience of isolation, and isolation and that kind of disengagement is if people aren't safe, I either have to respond to them before they respond to me, or I just keep withdrawing, which then leads to numbing, which then leads to self-harm, which then leads to suicidality. And so in this kind of progression and this kind of recognition, how do we address what we see in ways that are supportive, that help to create that safety that hasn't been there, and that reduces that isolation, and also creates experiences that some people are trustworthy. I think I mentioned in the first session, Bruce Perry's work has indicated that 3 intense relational experiences in an hour can begin to build a new pathway in the brain. And so that becomes so critical for all of us. It's not the length of time we spend with somebody, but it's the intensity of the relationship and the support and the valuing that then builds the brain. Because sometimes we negate, well, what kind of effect can I have? Well, all of us had experiences where we've connected just for a short time, but that has created an internal working model of the world that some people are trustworthy, some people do care. And so all of us then, it should empower, no matter how brief, to be able to give those experiences that an adult or a child may not have had. So I just wanted to show you this because becomes a real important picture of that betrayal. And this was a very middle-class family. And the woman in the middle who has the cloth over her, the sheet, was a student of mine. And she talked about in her house, she experienced significant emotional abuse and this kind of that she was invisible. And so her mom, who she talked about, had a presentation as a middle class that everything was good, but when she was with mom, it was very harmful. And so it's always felt like a spear going through her heart, and that then she wasn't noticed or didn't have value. And this affected her ongoing relationships. The only close relationship she had was the dog. And the dog, as you see below her, is the one standing close as some sense of safety. And one of the things I've learned, and I'm not a big animal lover to a degree, but we've had a therapy dog for a while now at the center, and the kids have really appreciated. And I've seen just what animals can do that people can't. And sometimes we negate because we think, well, what and how does a relationship with an animal become more powerful than a relationship with a person? Well, one, there's acceptance, there's a belief from the child that this dog likes me, there's positive reinforcement, all of which adults often don't do that animals can. So I'm going to stop there for a minute. I know we got a few more minutes, but just if there's questions or thoughts people have.
We do have a couple questions in the chat. Emma asks, what can be done in adulthood to mitigate the effects on brain development caused by trauma?
So, great question. So, first is we know that relationships, having safe relationships where you feel valued and wanted, whether it's in childhood or in adulthood, is the most powerful factor in being able to heal from trauma. And what that does is it creates a new pathway that somebody does find value. One of the things the researcher is a guy named Southwick and his partners Charney, and they've done lots of research. And what they found was even if a child doesn't have that relational connection in childhood, having a partner as an adult who they feel wanted, valued, appreciated can have a significant difference in healing in terms of in adulthood. And we call that earned security. So that there's in adulthood that opportunity to experience what you didn't as a child. And therefore, it does build new pathways in the brain. The brain is continually developing. Now, they say the brain develops kind of everybody's agreed at least till 25, but the more newer research is that it continues to develop. And so even if you didn't have that as a child, you can have it as an adult. The second part of that is then learning and building your brain in with coping strategies that then you're managing that trauma when it flips versus the trauma managing you. And let me just give an example that was very significant to me. So one of the teachers in Oxford who had been in the scene and significantly exposed to violence at the school that day, and had been affected for several months thereafter in terms of sleep, in terms of being unable to go places, in terms of this hypervigilance, ongoing suspicion. And so over time, through therapy, through being aware of himself, giving language to his experience, when the MSU shooting happened and it triggered then obviously something in the Oxford folks, he said, instead of that shutting me down for 3 days, it shut me down for 15 minutes. I regrouped and then I could manage and tell myself what's happening in the here and now. Because the other part of this is where we move when we get triggered, we're back in that scene from 5 years ago, 2 years ago, versus no, I'm in the present. And so such things as fidgets helps us to be present, breathing, all of those ways that we can say what's happening now versus I'm back then. One of the coping strategies in a particular treatment is called SOS, slow down, orient to the here and now, and then where's your stress at? And then how do I turn that stress down? So if it's a 10, how do I turn it down to a 3? What do I do? And how do I practice? Because the other part is practice. If we know it, prefrontal cortex, but we don't wire it in the rest of the brain through practice in motor memory, then it won't be available when we need it. So there's number one. Okay.
Okay. Our next question is, what is the difference the children who have ongoing instability and trauma and those who experience one-time but very large traumatic events, for example, the children in Norway?
So two things. What we know in the research, this researcher did it as well, the greater experience, let's just talk about Norway for a second, the greater trauma that you had had before that day of the shooting, the greater likelihood you would have significant PTSD symptoms, right? So prior exposure to trauma creates vulnerability that having that happen is going to have more significant effect on your functioning in terms of compromising, because it triggers the memories of your own trauma and puts that brain into fight flight. The second is that when a child or an adolescent or an adult experiences a trauma, and he has someone with whom he has safety, that person acts as a buffer to minimize the symptoms that might be skyrocket for others. But because he has this buffer or she has this buffer, they're not alone. They feel safe with someone that mitigates the long-term effects. So prior history increases, having someone with whom is a buffer decreases the impact of a significant event. Now, that doesn't mean that there won't be triggering in that significant event, but that ability to significantly alter functioning will be significantly reduced in that way.
Do we have any other questions or comments for Dr. Henry?
Well, let me just wind up because we only have a couple minutes. And with the recognition that all of us, as we talk about reducing the effects of trauma, have the potential to significantly reduce impact. And that is to be able to provide that safety to someone. In other words, I'm here to listen. I'm here to be with you in your pain. I know you're trying the best you can, and right now it's very difficult. And I can't underline that enough, because one of the things we do is we minimize how adults and kids are trying and believing they're doing the best they can. And when a person hears that, it reduces the shame, it creates a connection, and it provides that person with the understanding that somebody gets me and I'm not alone. When I was sitting with that 15-year-old yesterday, one of the things as we were going through and we talked about distrust, abandonment, rejection, and I said something about, and my experience is then because of that, you have to test everybody. And he looked at me and had a very big smile on his face. He says, wow, you really know this stuff, don't you? And again, it wasn't about me at all. It's about what kids have taught me, but just giving language to it, that you're normal. Yes, this is, because kids nor adults know their responses are normal, and that then by normalizing, we provide them safety, that there isn't something wrong with them, but rather it's what happened to them. So I'll stop with that. So thanks, everybody. Appreciate your time and your willingness. And please feel free to let Kristen know if you have questions in the future. I'll be glad to do the best I can to respond to them.
Well, thank you, Dr. Henry. And we actually have 2 more webinars coming up with Dr. Henry in 2024. Those subjects are trauma screening and assessment for children and adults. And the other one is the power of resiliency to heal trauma, build mental health, and restore functioning. So I don't know, Dr. Henry, if you have anything you want to add about those 2 upcoming webinars.
I'm just really excited about both of them because we've done so many trauma assessments, over 6,000. And so there's something to be learned in how and to screen for trauma as well as to assess. And certainly one of my favorite words is resiliency. It's the ability to overcome adversity. And how do we do that? And we've talked about certainly some of the ways today, but how do we build on that? All right. Well, thanks, everybody.
Thank you, everyone.